Welcome to the webinar dedicated to cardiac anatomy as organized by the European School of Radiology for preparation to getting the European Diploma in Radiology. My presentation will include the following three learning objectives: to become familiar with details on myocardial anatomy, to become familiar with details on segmental coronary anatomy, and to learn about the most common anatomical variants, anomalies, and potential anatomical tumor mimics. To meet these learning objectives, I organized my presentation into three main parts, including the normal cardiac anatomy and myocardial segments, the normal coronary anatomy and segment model, and the anatomical variants and tumor mimics. Well, all of you know the heart consists of 4 cardiac chambers, so that's not really new to you. However, all of these 4 chambers have distinct anatomical features, and it's very important to be familiar with these anatomical features and to know about them, because they can, some of them can mimic tumors, and this can lead to some confusion after echo, and patients are sent to cardiac imaging to rule out or to describe an intracavitary tumor. Let's start with the right atrium. It's a very important anatomical localization. We have 3 remnants of embryological structures within the right atrium, consisting on the crista terminalis, the valvula Eustachii, and the valvula Tibesii, and all of them can be misunderstood or mistaken as tumors or even as thrombi, and that's why it's very important to be familiar with all of these 3 structures. To be honest, I am confusing them sometimes as well, so it's one of the things that we have to look again every time when we are confronted. However, it's really important to be familiar and to know that these structures exist, to not just write down this is a thrombus or a tumor. So first we have the crista terminalis at the border between the embryological venous and muscular part of the right ventricle of the right atrial wall. This can be really a thick fold there, and this can look as a tumor, especially at echo in this typical localization. The valvula Eustachii is found at the confluence of the inferior vena cava, and this can be a very prominent structure as well. And especially at cine imaging, this can look a little bit larger and could give the impression that some tumor or thrombus is there. And finally, we have the valvula Tibesii at the confluence of the coronary sinus, seen here, and the shape of the coronary sinus can be very different, and even this could be misunderstood or misundertaken as a tumor or thrombi. We have as fourth very important anatomical feature in the right atrium, the right atrial appendage. Usually it has a triangular shape, and there is a large communication with the right atrium, which is a big difference to the left atrial appendage, since due to this large communication, thrombi are not that frequent in the right atrial appendage as compared to the left atrial appendage. However, thrombi can occur even in such an enlarged right atrial appendage. Let's move to the left atrium. The most important feature of the left atrium is the left atrial appendage. This could be enlarged, especially in patients suffering from atrial fibrillation, and then there is the risk of occurring of thrombi there, and this is a very serious finding, since thrombi in the left atrial appendage accounts for up to 30% of all ischemic strokes. So we have to carefully look at the left atrial appendage in all cardiac studies to be sure that we don't have something like that, which is a typical thrombus within the left atrial appendage, and which is a very important information to the referring physicians. The right ventricle can be identified by its leading structure, that's the moderator band, so you are always able to identify the morphological right ventricle. This becomes important, especially in congenital heart disease, where all the cavities could be exchanged. So you are able to identify the right ventricle from a morphological point of view by the identification of this large structure here, which is the moderator band. And it characterizes the embryological right ventricle, and it courses from anterior papillar muscle to the interventricular septum. So another enlarged right atrium, right ventricle, and here this really impressive moderator band, so it's obvious this is the right ventricle. Finally, the left ventricle, of course very important, it's usually the systemic ventricle, and it's the target organ for ischemic heart disease, so we should really carefully assess the left ventricle when we are doing cardiac imaging studies. And we should try to report the findings dedicated to the left ventricle myocardium according to the segmental model as introduced by the American Heart Association. To do so, the ventricle is subdivided into 3 zones, starting from the level of the valves, which is the basal zone. Then we have the mid zone, and finally we have the apical zone, and really the apex could be taken as another zone, but usually we are talking just about 3 zones from basal to apical. And within these 3 zones, coronary segments are described. 6 in the basal zone, 6 in the mid-cavity or medial zone, and 4 in the apical zone. And the segments included the anterior, anteroseptal, infraseptal, inferior, infralateral, and anterolateral for the basal and medial zone, and anterior, septal, inferior, and lateral for the apical zone. And we should try always to describe anomalies at the level of the myocardium according to this segmental model. And of course, we can assign different segments to the different coronary arteries. So we have the anterior and anteroseptal segments from apical to basal according to the LID. We have the lateral and infralateral segments for the circ, and we have the basal and the posterior segments as supported by the RCA. And that's very important to stick with this scheme when we're describing pathological changes at the level of the myocardium. Let's move on to the normal coronary anatomy. We heard that different parts of the myocardium are supported by different coronary arteries. So we have 3 main epicardial coronary arteries, and the leading structure for the coronary anatomy is the sinus of Valsalva. The sinus is subdivided by the cusps of the aortic valve into 3 parts, into the right sinus, the left sinus, and the non-coronary sinus, and it's very easy to understand why these sinuses are named like this. Since the right sinus of Valsalva has the ostium for the RCA, the left sinus of Valsalva has the ostium for the left main, and the non-coronary sinus doesn't have any ostium for a coronary artery in case of normal coronary anatomy. The right coronary cusp is the most anterior one, so the origin of the RCA is the most anterior one and really substernally. The normal coronary anatomy consists on a right coronary artery supporting the posterior wall of the left ventricle, most of the right ventricle, as well as the posterior parts of the septum. So as a rule of thumb, RCA means the posterior wall. Any change at the level of the posterior wall is due to something wrong in the RCA. And then we have the left coronary system consisting on the left descending artery, the LAD, and the circumflex artery, supporting the anterior wall of the left ventricle, the anterior lateral and parts of the posterior wall of the right ventricle, and even the anterior parts of the septum. So as a rule of thumb, the LAD means the anterior wall. Any changes at the myocardium in the anterior wall is due to changes at the level of the LAD. This can easily be understood if we look to two-chamber view of the heart. So we have the right ventricle here, we have the left ventricle here, we have the septum here, then this is the LAD, this is the RCA, and this is some branch of the circ. So it's obvious that all the myocardial tissue between these 2 arteries is supported by them. So it's obvious lateral wall, anterior parts of the septum, anterior wall of the right ventricle is supported by the LAD, and everything which is posteriorly is supported by the RCA. To be able to compare our reports with findings at the coronary angio and to describe pathological changes, the segmental model has been introduced. There are a lot of different segmental models available in the literature. However, the 15 segments model, as introduced by the American Heart Association, is currently the most commonly used, and I will introduce in the next couple of minutes this 15 segment coronary model to you. Let's start with the RCA. The RCA courses along the right AV groove, and very important for the naming of the coronary artery is not the origin, but the course is the most important one. So independent where the artery is occurring, the artery within the right AV groove is the RCA. After that, the RCA curves posteriorly at the acute margin of the right ventricle to reach the crux of the heart, and finally the RCA is supporting the even the very, very posterior parts of the right and left ventricle. It starts with the segment number 1. It's the proximal RCA coming from the ostium of the RCA to 1/2 of the distance to the acute margin of the heart. So on the axis, on the normal axial slices at CT, the proximal RCA is usually seen in a horizontal shape. So this is the proximal segment, segment number 1 of the RCA. The mid-RCA is from the end of the proximal RCA to the acute margin of the heart. So this is the part of the RCA usually seen at axial CT slices in a really orthogonal shape. So this is the mid-RCA, and we can assess the RCA really nicely here on this kind of images. And the next segment, segment number 3, is the distal RCA from the end of mid-RCA to the origin of the PDA. So up to the crux of the heart, as seen here. So this is the distal RCA up to the branching at the crux cordis, and supporting the really diaphragmatic aspects of the heart. On the way down, there are some marginal branches or acute marginal branches of the RCA for a supply for the free border, free anterior wall of the right ventricle. However, they are not named separately at the 15 segment model, so they are not counted as defined coronary segments. This is one such an acute marginal branch of the RCA supporting the free anterior wall of the right ventricle. Distally to the crux cordis, there is the branching into the posterior descending artery and the posterolateral branch for support of the very posterior parts of the right and left ventricle and the posterior parts of the left ventricle. And if the PDA and the PLB are supported by the RCA, then we are calling this a right dominant supporting type. The PDA extends down the posterior interventricular groove up to the apex of the heart, and the posterolateral bundle or posterolateral branch gives at least one other branch laterally to the PDA to support the posterolateral parts of the left ventricle. The RCA gives rise to the PDA and the posterolateral branch. Then we are called this a right dominant system, and we found the right RCA dominance in about 80% of the normal population. If we have support of the PDA and the posterolateral branch, not by the RCA but by the circumflex artery, this is called the left dominant system, which can be found in about 10% of the normal population. And if we have shared support, that means the RCA gives rise to the PDA, but the circ gives rise to the posterolateral branch, then it's called a co-dominant system, which can be found in the last 10% of the normal population. So right dominant system is the most frequently seen supporting type. The left coronary artery arises as the left main from the left sinus of Valsalva, and the left coronary cusp is the most cranial one at the sinus of Valsalva. So the next coronary segment is the segment number 5. It's the left main. There is a huge variation in the length of the left main, and per definition, the left main is from the origin, from the left coronary ostium to the bifurcation into LAD and circ. So this is, in this case, a rather long left main, nicely seen, up to the branching into LAD and circumflex artery. The LAD runs in the anterior interventricular groove along the ventricular septum, and again, independent where the LAD, where the ostium is, the artery within the anterior IV groove has to be called the LID. The proximal LID, it's the next segment, is from the branching out from the left main up to the branch of the branching of the first diagonal branch here. Nicely seen here, so that's the circ, and this is the first diagonal, and this is the proximal LID. The first diagonal branch, it's an important branch for support of the anterolateral parts of the left ventricle, and it's the segment number 9, nicely seen here, a very large first diagonal branch. After branching of the first diagonal branch, the LID is not anymore the proximal one, it's the start of the mid LID. So the next segment is the mid LID from the branching of the first diagonal up to the branching of the second diagonal, or to 1/2 to the distance of the apex in case of missing a second diagonal branch. So here between the first and the second diagonal we have the mid LID. The next segment, segment number 10, is the second diagonal branch, another branch to the lateral part of the left ventricular myocardium. Here we see the second diagonal branch. And distally to the branching of the second diagonal, we have the distal LID, which is the last segment of the LID, up to the very final end of the LID at the apex of the heart. There is a huge variation about the diagonal branches, so we can have only one branching again into some branches of the first diagonal, or we can even find 2 or 3 diagonal branches. Huge variation, and it's very much important to describe any anatomical variants within your report. Finally, we have the circumflex artery as some kind of the mirror of the RCA. So the circ courses in the left AV groove, and in case of right dominant individuals, the circ is a rather small artery terminating at the level of the obtuse margin. So the distal circ might be missing in right dominant individuals. Let's go through the segments. From the end of the LID to the first obtuse marginal branch, we are calling this circ the proximal circ. From the branching of the first obtuse marginal up to the second obtuse marginal, it's the mid circ, nicely seen here. And distally to the branching of the second obtuse marginal, it's the distal circ. And in case of left dominant type, this distal circ will support even PDA and PLB. In case of right dominance, the distal circ usually is very hypoplastic. So this is a case of a left dominant type. We see here support for the posterolateral branch, and here the connection to the posterior descending artery in this left dominant type. And the last 2 missing segments are the first obtuse marginal branch, supporting the lateral wall of the left ventricle as well, and the second obtuse marginal branch. And this might be absent in a case of right dominance, or this could also be the final destination of the circ in case of right coronary artery dominance. So that's the second obtuse marginal branch supporting the posterior parts of the lateral wall of the left ventricle. The most common anatomical variation at the level of the left coronary anatomy is the so-called intermediate branch. It's a fusion branch between the first diagonal and the first obtuse marginal branch, so we don't have a bifurcation between LID and circ. We find a trifurcation between LID, circ, and intermediate branch, and this intermediate branch runs as a diagonal branch or even as an obtuse marginal branch down to the lateral wall of the left ventricle. And if such an intermediate branch is present, usually we see just one diagonal branch and or just one obtuse marginal branch. So this is such an example of such a trifurcation: left main, LID, intermediate branch, and a circumflex artery. So to summarize up the normal anatomy, the 15-segment model as introduced by the American Heart Association is currently the most important one and clinically used one. We should stick to this segmental model, and we should do the segmental assessment of the coronary arteries, and we should always indicate the supporting type to lead even the treatment. Just a few words at the final end of my presentation to the anatomical variants. What is normal, what is abnormal? So per definition, normal is any morphological feature observed in more than 1% of an unselected population. A normal variant is another, not as usual feature, but also seen in more than 1%. And an anomaly is an unusual feature seen in less than 1% of the same population. Coronary anomalies is any coronary pattern with a feature rarely encountered in the general population, and there are different types of coronary anomalies, including anomalies of the origination and course, of the intrinsic coronary anatomy, or of the coronary termination. The anomalous collateral vessels are not a task for our imaging modalities, but the group A to C can be nicely seen and diagnosed based on cardiac imaging. So that's one example of the most common coronary anomaly according to the origin and course. And as mentioned before, for the naming of the coronary artery, not the origin, but the course is important. So of course this is a circ because this artery is going to the left AV groove, but in this case the circ originates from the right sinus of Valsalva. We have different types of this kind of coronary anomalies. We can distinguish between the so-called malignant and the benignant anomalies. Good news, the benignant ones are the most common ones, and we have seen the really most common, which is an anomalous circumflex artery. Two examples for malignant course. So we are talking about malignant course if we have an intra-arterial course of the anomalous coronary artery, in this case the RCA, originating from the left sinus of Valsalva and showing this course between the aortic valve and the pulmonary trunk. And the second possibility is to have a left main coming from the right sinus of Valsalva, showing this intra-arterial course as well. And this is called a malignant course of coronary anomalies. Our example, for sure, is a retroaortic course, so it's not between two high-pressure systems, and that's an example of a benignant coronary anomaly. There's another example, very rare case, where we have just one coronary ostium, and of course we have a malignant course of the left of the LID, because the LID is crossing between the aortic root and the pulmonary trunk. We have anomalies of the intrinsic coronary anatomy, including absent coronary arteries or even myocardial bridging or muscular bridging. So this is one example where the coronary artery is surrounded by myocardium and not by fatty tissue. So that's one example of an myocardial bridging, which is a really frequent finding. So if you look carefully at your CT studies, you will see something like that very frequently. And finally, anomalies of the coronary termination. That means all the groups of the coronary fistula, a very excessive coronary fistula in this case, just to give you an impression about that. What is really important talking about coronary anomalies? Well, the malignant course is very important because this might be the reason for sudden cardiac death. So if we have a left coming from the right and from right sinus and crossing between a pulmonary trunk and aortic root, then it's a malignant anomaly, and this is a very important finding. And coronary fistulas can lead to volume overload. Such a huge one, as seen before, will lead to volume overload over time. In all the other coronary anomalies, the relationship to the symptoms usually remain unclear. Most of the coronary anomalies have no clinical impact. However, they can have some impact when it goes to treatment, so that's why it's very important to report them in our clinical reports. So thank you very much for listening to this webinar, and at the final end I will just show you two cases and will ask some questions with regard to these cases, and of course the two cases are dedicated to coronary anatomy. First, we have a female patient, 68 years old, suffering from atypical chest pains, no cardiac risk factors. That's why coronary CT was indicated to rule out or even to confirm the coronary artery disease. So in this, these are the images as obtained. So we have the maximum intensity projections here, and we have the volume rendered image here. So maybe you should focus on that. and I would like to ask you which statement according to this case seems to be appropriate, which is the appropriate statement. Can we say, well, symptoms are caused by the coronary artery disease, the symptoms are typical chest pain? Do we have a benignant coronary anomaly? Do we have a malignant coronary anomaly? Do we have a coronary anomaly very unlikely a cause of symptoms? Or do we have an aortic dissection, Stanford type A? Of course, in this case, we have a so-called malignant coronary anomaly. So we have this LID coming from the right sinus of Valsalva, and with this intra-arterial course between the aortic root and the pulmonary trunk, nicely seen on the volume rendered image as well. And per definition, that's a malignant course of the left main, and there is the risk of pressure and during exercise, and this could lead to arrhythmia or even to ischemia during exercise in this case. So the intra-arterial course, and this is the take-home message of this case, the intra-arterial course of an anomalous coronary artery per definition has to be called a malignant. However, the symptoms are not necessarily related to the anomaly. In this case, it's a rather old patient suffering from this malignant anomaly. However, it's very important to indicate in the report. And again, for appropriate naming of the coronary artery, not the origin is important, but the course. So in this case, we have the artery going to the anterior IV groove, and of course, this is the LID. Even if the branching and the origin is at the right sinus of Valsalva. And there are some very good and important papers. First of all, on the reporting system, rather old, from 1975, introducing the segmental model. And this is a very, very good overview paper about the different types of coronary anomalies, including incidence and pathophysiology. Let's move on to a second case. Another female patient, 68 years old, suffering from atypical chest pain. And even in this case, CTA was done to rule out coronary artery disease. And these are the images as obtained. And my question is rather easy. What's your diagnosis in this case? Just some maximum intensity projections here, and the question remained the same. What is your diagnosis in this case? Even colored images, giving a really nice impression on everything. So is it a coronary fistula from RCA to pulmonary artery? Is it a coronary fistula from RCA to right atrium? Is it a coronary aneurysm? Is it a pericardial cyst, or is it a coronary fistula from RCA to the left ventricle? So it's not only the diagnosis, because we have seen the image in my presentation before, but it's even from the origin and the end. And in this case, we have a coronary fistula from the RCA to the right atrium. And this leads to this volume overload even of the right heart. Let me summarize even this case. Coronary fistulas are rare coronary anomalies. Coronary fistulas can occur from every coronary artery and can end up in almost all cavities around. And large fistula become clinically relevant due to the volume overload, as it was the case in this patient. So this patient was in need for undergoing surgery. Again, some references, of course, very similar to the previous one dedicated to the segmental model and the other one to the giving an overview about the coronary anomalies. Thank you very much for your attention.